Hello, my name is Rhonda Dickman. I'm a registered nurse and clinical quality improvement specialist with the Tennessee Hospital Association. I lead THA's efforts to support hospitals in reducing sepsis mortality. In this issue of Sepsis Journal Club, we're taking a look at the article Fluid Response Evaluation in Sepsis, Hypotension, and Shock, a randomized clinical trial. This article was published in Chest in August of 2020. It is a report from the FRESH trial and is available as a free full text on PubMed. In introducing the topic, the authors state, fluid and vasopressor management in septic shock remains controversial. And while fluid resuscitation is a central component of septic shock treatment, excess fluid administration is associated with patient complications and higher mortality, and evidence shows that 2/3 of patients with septic shock demonstrate fluid overload on day 1. Current guidelines recommend 30 milliliters per kilogram of crystalloid fluid resuscitation for septic shock, with additional resuscitation requiring assessment of fluid responsiveness. Only a half of septic patients will be fluid responsive, and in a propensity model analysis of over 25,000 patients with sepsis, day 1 fluid administration greater than 5 liters was associated with an increased risk of death. Traditional methods for assessing fluid responsiveness, including vital signs, physical exam, static measurements of circulatory pressure, do not reliably correlate with fluid responsiveness. Dynamic measurement of stroke volume after IV fluid bolus or passive leg raise is safe and feasible, and it's associated with reduced length of stay, fewer post-op complications, and earlier return to regular diet among surgical patients. The use of non-invasive bioreactant stroke volume and cardiac performance measures with ICU septic shock patients has been associated with a decreased net fluid balance, reduced ICU length of stay, reduced risk of mechanical ventilation, less time on vasopressors, and less risk of renal replacement therapy initiation. So given these factors, the primary objective of this trial was to determine if stroke volume guided dynamic assessment could guide the amount of IV fluid given to septic shock patients. This was a randomized, unblinded clinical trial among adults with sepsis-associated hypotension. The study compared usual care to passive leg raise guided stroke volume responsiveness as a guide for fluid management. Participants were randomized in a 2-to-1 allocation of stroke volume guided to usual care, and all non-fluid related sepsis care was provided to both groups per usual institutional practice. Participant inclusion criteria are as follows. They had to have a positive screen for sepsis, severe sepsis, or septic shock based on Sepsis 2 criteria, with an anticipated ICU admission. They also must have refractory hypotension, which was defined as a mean arterial pressure less than or equal to 65 after receiving greater than 1 liter but less than 3 liters of IV fluid. And they needed to be enrolled in the study within 24 hours of arrival. Exclusion criteria included patients who had received greater than 3 liters of IV fluid before random assignment, patients that were active do not resuscitate, had active hemorrhage, had been received as transfer from another hospital, or had a serious acute event occurring at the same time, such as these listed here on the screen. In the intervention arm of the study, passive leg raises were performed before any treatment of hypotension with either fluid bolus or vasopressors for the first 72 hours of ICU admission. Stroke volume guided fluid and vasopressor management were used continuously through the intervention period, which was the first 72 hours or until ICU discharge, whichever came first. And fluid responsiveness was defined as an increase in stroke volume greater than or equal to 10%. Fluid responsive patients were given a 500 milliliter crystalloid bolus with repeat passive leg raises after each bolus. If the patient was not fluid responsive, the initiation or up-titration of vasopressors was prompted with repeat passive leg raises after a significant increase, for example, 1 microgram per kilo per minute of norepinephrine. And these are the results. Between October 2016 and February 2019, 124 patients were enrolled, which was the statistically significant sample. In comparing the intervention group and the usual care group, the number of SIRS criteria present on admission, very similar. The amount of fluid volume the patients had received before enrollment in the study, very similar. And the baseline comorbid medical conditions were similar as well between these two arms. Additional results are provided here, with those in bold representing the ones that reach statistical significance. The positive fluid balance at 72 hours or at the time of ICU discharge, whichever was earliest, was less in the intervention arm, and on average 1.37 liters less of fluid than the usual care group. There was significantly less initiation of renal replacement therapy and mechanical ventilation. The ICU length of stay was less but not statistically significant, same for vasopressor hours. And again, the change in serum creatinine was different but not statistically significantly different. Discharge to home was significantly higher in the intervention group, and the 30-day mortality rate was lower, although not statistically significantly lower. A total of 523 passive leg raises were performed in 83 of the intervention patients. Among those, 42% of patients were fluid responsive on their initial passive leg raise. A third were fluid responsive between 48 and 72 hours. 82% were fluid responsive at least once. 12% were persistently fluid responsive at each measurement, while 18% never demonstrated fluid responsiveness. In discussing these results, the authors state, passive leg raise rapidly displaces about 300 cc's of venous blood to the chest, transiently increasing preload and identifying whether subsequent fluid administration is likely to enhance cardiac output. If the stroke volume increases by greater than or equal to 10%, a subsequent 500 milliliter fluid bolus will increase cardiac output by at least 15%. Passive leg raise guided resuscitation in this study resulted in significantly lower net fluid balance and reduced renal and respiratory dysfunction at 72 hours, which supported the author's hypothesis. Because only 50% of patients were fluid responsive, usual care fluids are administered when there's minimal to no perfusion benefit. Lastly, the authors state that fluid responsiveness was not static in this study. Patients would often have a change between responsive and non-responsive states during the 72-hour study period, and therefore the study benefit may have resided in the timing of fluid administration rather than having a lower positive fluid balance at 72 hours. As stated at the beginning, this interesting article is available on PubMed as a free full-text article.